so then it kind of falls to me to like just, we gotta have the drape open, otherwise it can form a little dam there, and then you're working in like a fishbowl instead of an operative field. There we go. It's very common that patients will be extremely uncomfortable with an eyelid speculum in. Actually, well, it's not that common, honestly. Like, it's surprisingly uncommon when you really think about how that looks.
Yeah, right.
When you think about how that looks, it's surprisingly how comfortable it actually is. And I've had an eyelid speculum in my eye, and maybe you should try it too. It's not that bad.
I have had
Have you?
Yep.
Amazing.
And you're right.
Hi, Cynthia. How are you doing? You feeling fairly relaxed? So, Rebecca, we make 2 entry points into the eye. And these instruments that I'm using are made of sapphires, synthetic sapphires.
Cool.
That's why they're clear. It's an actual gemstone. We have diamond ones too. But I let the other doctors use those because they are really, the other guys are really particular about that. But when you use the diamonds, somebody always drops it, and it's $5,000. So I just use sapphires. They're great, and it's just a lot less stressful. I mean, it would be like the diamond's chipped, and then they're trying to figure out who did it. Well, I saw Dr. Smolik was holding it in his hand while he was adjusting the microscope. You know, because they don't want the doctors to think the staff did it. Like, nobody wants to be responsible for the broken diamond. And these sapphires are nice. They're about, I think they're about $125 each, and you can use them like 50 times before they lose their edge. Yeah, they're really, really nice.
Or the diamonds more like you can use them until
You can use them until you drop them, yeah.
Yep.
Like, they don't really lose their edge.
Yeah.
Yeah, they have to be, but they're very, very brittle, and they can be so easily damaged. Like if you just kind of touch it to the lid speculum, or someone clinks it together. Sometimes they can be repaired, but even that's hundreds. Sorry, I've got to get my edge here. There we go. How are you doing, Cynthia? Are you feeling a little pulling on your upper lid there? I'm just kind of pushing on your eye opener to try to open up my view a little bit as I try to make a perfect circle. There we go. Hey, that is very, very nice. How are you feeling, my dear? No comments. Okay. We'll take that as a good sign. What about the table?
She's scratching the table.
Oh, Cynthia is?
Yeah. Mm-hmm.
Cynthia, are you comfortable? Are you feeling okay?
I think so.
Oh, good. Someone noticed that your hand was kind of like fidgeting on the table, and I just want to make sure you're not in any pain. So you're going to be practicing up in Spokane, Dr. Gillis.
Yes.
How did you find this practice? Did you just write them a letter?
They have been putting out things on the Oregon optometry website.
Oh, well, that's what I need to do.
Right? They want a resident trained dry eye specialist.
Oh, no kidding.
And a lot with dry eye research and stuff.
Well, it's like a moneymaker lately, right?
It definitely is.
And you know, honestly though, can we just say I think Procara is kind of fake.
Yeah.
Am I gonna hurt your feelings if I say that?
But it's not gonna be really a long lasting.
I mean, $800,
Yeah.
and the company's like, "Whoa, look at." If you're ever selling something and the first thing out of your mouth is how much the reimbursement is, and go to the next office.
Yeah.
I don't know. It's like maybe I'm old, but I have rarely seen a patient who, if they diligently did artificial tears and warm compresses, didn't get better.
Yeah.
And if that doesn't work, I make them take fish oil. And if that doesn't work, maybe I'll put them on some Doxy. Maybe some punctal plugs if there's no inflammation. And like, I have, I don't know. It just seems like it always gets better, but the ones that don't get better, like they didn't do what we told them to do. And we're just saying like a little too quick to be like, oh, you need LipiFlow. Okay, but are you really using a hot washcloth? Maybe you should do that first.
Great.
I'm a believer in ocular surface disease. You know what? I don't really. I will just confess to you. One thing I'm not really confident about is Demodex.
Oh, yeah.
I am not sure I could diagnose a case of Demodex. I'm sure I am literally blind to it because I don't really know what to look for. You should teach me.
Definitely just like the type of blood you're seeing, the cylindrical base collarettes.
Really?
Yeah, there's a really, really high correlation.
Would you say
So
that-
you can almost bet
Huh.
if you see like that.
So you don't have like a light microscope and like you pull them out and look at it on a microscope,
I don't.
but you judge if they have collarettes. Then you just say, is it 100% sensitive and specific?
It's pretty high. It's not 100,
Huh.
but it's very high.
What other contributing signs would lead you toward a diagnosis of Demodex?
Lid itching.
My eyelids are itchy.
Itchy. Yeah.
Huh. Symptoms of itchiness. But otherwise, you know, how am I to differentiate Demodex from posterior blepharitis and meibomian gland dysfunction and someone who just doesn't wash their face?
Right. And maybe that is do the things like lid scrubs and stuff, and then it not.
So how do you treat them?
Tea tree oil, lid scrubs. Although Dr. Edwards pointed out using ivermectin.
Yeah.
So-
That's
That would be good.
yeah. There's a lot of talk about that. You think tea tree oil really works? We're at 146 axis.
It's what a lot of the left and
Yeah.
faces.
I went to the Virginia Society of Ophthalmology in 2009, and I got my breakfast and I sat down, and then I was at a table by myself, which is okay. I like it sometimes. And this older doc, I remember he was Asian. He sat down next to me. He was very nice, and he's like, "Oh, what are you working on? What's your name? Nice to meet you. I'm Schaefer." And later on, someone's like, "That was Schaefer Singh.
Yeah.
He invented amniotic membrane." I had no idea. He was very pleasant, and then he turned out he was the keynote speaker.
Oh, cool. That's super cool.
Yeah, it was neat. So here you got a lid fissure that's a little challenging. Like exposure's a little difficult. But we've got such a very nice patient, holding so still for me. Not a whisper of complaint from Cynthia. But once again, it's kind of like the view that is challenging. I tell you, so I'm trying to clean up this capsule. But it's like, if Matt breaks the capsule, it is during this step where the cataract's really out, and I'm just trying to get those like last little strings. That's when I break the bag. That is when I break it. Not really so much during phaco, it's during capsule polishing, just because I really, really want it to be clean. And it's hard to know like when you should just walk away. Like when is it good enough? Just a little bit more. Like, but I can't leave her with those strings in her. Can you see those?
Well, that one can kind of leave the pressure space.
Yeah. Oh, well, the viscoelastic, yeah.
Oh, okay.
Viscoelastic, not the cortex. These are like little cortical strings, so if I leave this, she'll get PCO pretty quickly. And also, if I need to rotate or reposition this lens, if the capsular bag is all fibrosed from all this cortex that I didn't clean up, it's going to be really, really difficult. So, but you have to know when. You have to know when to declare victory. Like, I think that is looking pretty clean. These lenses are hard to rotate. Sometimes I like to rotate them counterclockwise, but they don't want to rotate counterclockwise. They only want to rotate clockwise. It's kind of like swimming uphill, or swimming upstream, not uphill. Yes, that's about 135. Maybe that's probably right on axis. Let's form the eye up and finalize the position of this lens. You know why ophthalmologists have plus cylinder phoropters? Well, I don't know why we have plus cylinder phoropters, but I think one of the reasons that plus cylinder makes sense to us is because when we operate and we correct astigmatism, we correct astigmatism by placing incisions or lenses on the steep axis.
Okay.
Yeah, so it's kind of nice when the refractive cylinder is just at the same axis as your, kind of the axis marker, same axis as your surgery, basically. So we want to be at 146, which is really right there. So it's on. I am a human protractor. Muxidex. Actually, really, more than anything, I'm a human protractor. Look straight ahead. Like, you can learn anything, but I tell you, when I was younger, and if you would have told me to orient something at 146 degrees, you would have just received a blank look. Sorry, Cynthia. I'm sorry if that stings. What you're experiencing right now is completely normal. Stay with me. Good. Okay. Should be feeling better soon. Okay. Well, you know how I promised you 4 an hour?
We're taking all the monsters off here.
Alright, we're all done. Just sticky drape up now, okay? Very sticky, try not to squeeze your eyes. Be gentle. There's no other way to take this off, don't worry. Try not to squeeze your eyes. That was a little super fast. Sorry. One more. There you go. One more sticky. And I'm just gonna clean your face and sort of like that. I'm gonna give you one eyebrow, okay? Get some drop order.
Alright. Go ahead and open that left eye for me. I'm just going to put a drop in. Go ahead and look up towards your forehead.